would encourage you, if you do want to go out and see Longmeadow, it's a really cool facility in the back of a little suburban area, which is very different than a lot of other facilities, so it has a very homey feel to it. So I'm going to talk to you guys today about the concierge model of medicine, why I broke away from corporate medicine and went into it, but also just why I'm hoping that more and more physicians move to that model in primary care. Some specialists have done it as well, but also why I hope that more patients look at primary care models like that instead of just the traditional sense. So the best way for me to describe why I left corporate medicine or why other doctors are leaving it is to tell you kind of some of the secrets of the trade as to how we get paid from big corporate bodies, Baylor, THR, HCA. Then I can describe better why I chose to leave, some of the restrictions that are on there, and why I'm trying to empower more physicians to follow my model. So when you're leaving residency, you're looking for these different jobs, coming out of residency with $200,000 to $300,000 of debt. The idea of opening your own practice, of getting a business loan, is a joke. There's no bank that's going to look at your finances after making $40,000 to $50,000 for a few years and say, well, yeah, I think you're in a great financial position. Your debt asset ratio is absolutely terrible, but here's another couple $100,000 to go open a practice. So most of the time, you look at these offers from a corporate setting. They're giving you a big signing bonus, relocation fees. It sounds amazing, wonderful salary. And I don't blame anybody, just like I did. When you leave, you take that kind of job, there's some security to start paying your loans back. The problem is, the way that we get paid is all based on RVUs. So an RVU is a relative value unit that is placed on a certain level of care. It happens in the hospital, in the nursing home, but in a primary care clinic, I can give you examples on the prices. So Jeff comes in to see me, and he has a sinus infection, and I code him at a level 3. Most hospitals are going to pay a doctor somewhere in the $40 range for that visit. What Medicare reimburses for that is closer to $97 to $100. Private insurance is paying 2 to 3 times that. So you see the giant profit margin there that the corporate is going to make on top of the work that a physician is doing. If he came in for something a little more serious, such as AFib, diabetes, hypertension, and we decide, okay, this is not just a self-limiting thing, we're going to treat it a little more aggressively. We bill it at a level 4. Those are usually the 2 levels we're going to use. We would get paid 1.5 RVUs, which is roughly $60. Again, Medicare is in the $100 to $150 range. Private insurance is $200 to $300. All that's fine until you realize where that profit money is going to. I'm not saying that we should make more money, but when my MAs and my staff and my front desk cannot get bonuses and are not having their pay increased, and my administrators are making bigger bonuses than I am, not Peter, in a different sense, but when they're making bigger bonuses than the physicians, I should feel upset about that. The money has to be spread further across the board. So if you went into private practice and you wanted to say, okay, well, I'm cutting out of corporate stuff and I'm just going to do my own thing because I didn't have student loans, or I'm in a place that's underserved and they're going to pay back my loans for me. The issue with that is the negotiated rates are going to be lower because you're not part of a big group. So again, Baylor, THR, HCA, they can negotiate these very, very good payments because they say, well, we've got 1,000 doctors in the DFW area, so we're going to be sending lots of stuff to you guys, et cetera, et cetera. But when it's just one physician, usually it's 70 to 80% what those companies are making. But you now have to hire multiple people in your office to see more and more patients, to do referrals, to do billing. And that's why when you're opening that type of practice, you're looking at a $50,000 to $100,000 to open a practice that size. The frustrating thing, I think, for me when I was in there was after your first year of any contract with any of these companies, everything changes to straight RVUs. You get a nice guaranteed salary your first year, everybody's happy, you think it's great, and then the first year comes off and they say, listen, if you don't cover your salary, it's fine, you're $20,000 in the deficit, but once you finish your contract for 3 years, we'll wipe it clean. Year 2 comes along, and you're cruising along, seeing 15, 16 patients a day, and suddenly you realize, well, wait a minute, I'm not covering my salary anymore because the RVUs that I'm getting are not matching up to that, let's say a $200,000 salary. So imagine if you just did the simple math and how many patients you need to see a day to match a $200,000 or $250,000 salary that a physician leaving residency thinks that they're going to make because that's what they're offered that first year. Suddenly you're looking at 20 to 30, 30 to 40 patients a day. So for people who see regular physicians, I would hate to believe that that doctor really just says, I don't care about my patients, I only want to spend 10 or 15 minutes. But that's the financial side to it, where they're saying, I have to cover my salary. And the only way I do it is one way, more and more patients. That's the frustration that all patients will experience when they go to any of these larger corporate offices. My visits were 10 to 50 minutes long. I would go home at night, feel that I did a terrible job, even though people felt that I was doing a good job and I was meeting quality bonuses. I just didn't feel that I was spending enough time with my patients. I think that my MAs didn't feel that they were doing anything either. It was really just an assembly line. I had 15 to 20 phone calls and emails, usually from people I've seen in the last couple of days that just said, hey, I forgot to ask you this question. And I don't blame them. I went to med school when I was in my late 20s, so I was a regular patient that didn't know anything about medicine, and my frustrations that I had, I totally understood where the patient was coming from. So, one other very interesting thing, the last time I was here, there was a guy, I think he was from United Healthcare, giving a talk. This was a few months ago. So I started researching and saying, well, you know, everybody complains, Medicaid, Medicare, they're all crap, like, et cetera, et cetera. Well, what do you think United Healthcare's gross revenue was last year? Somebody throw a random number out there.
5 million.
So, their earnings were over 10 billion. Their gross revenue was 200 billion. Here's where you put this in perspective for somebody who's not from the States. The GDP of my country is $20 billion. So how does an insurance company make earnings of half the GDP but make gross revenue of 10 times that? That's absurd. So I just said, listen, enough is enough. I'm going to go into something different because I'm not happy practicing the way that I was practicing anymore. I was in corporate medicine for 6 years. And I started just looking into what people call concierge practices. Some people call it direct care. There's a differentiation between them. I just look at it as a membership type practice. So I did some research in the area that I was in, because if you go down to downtown Dallas or Fort Worth, there's some concierge practices that are $400 a month, $15,000 a year, and they're aiming for 20 families. There's this famous show on USA called Royal Pains out in the Hamptons. And that's exactly what those practices are like. They have 30 families, they take care of them, make $300,000 a year, don't have an office, and that's fine. I didn't go to med school to take care of those people. I wanted to create a practice that whether I was Mark Cuban or a janitor in a hospital, that if you can afford $75 a month, that I would take care of you. And so the practice that I created, that's exactly what the price is for an individual. You get unlimited visits, your blood work's free, EKGs are free, joint injections, pap smears, and I'm adding x-rays next year. So the first thing that my patient said to me when I was leaving corporate, and this is not a joke, but Dr. Stone, how are you going to make any money? Well, when's the last time a patient has cared about their doctor not making enough money? That to me was a very touching point because it really made me feel that these people enjoy the way that I practice, but they were worried that going into this type of practice that I wouldn't make the money that I wanted to. In my mind, I said, listen, there's no poor doctor in the world, definitely no poor doctor in America. We may think that we're not making what we want to make, but when you look at what percentage you fall into in the worldwide income, you're still in the top 5%, no matter what. So I just said I wanted to enjoy this again. My hours when I was working at the nursing home when I was at corporate was 6 a.m., noon, and 6 p.m. because you couldn't leave. You were just there in the office, just waiting for patients to show up. And there were too many times I had the regional director or the area district director coming in there, and it frustrated me that these guys who knew nothing about medicine were trying to tell me how to run a practice. So the beautiful thing for me about my practice, I don't have a nurse. I do all the vital signs. Everybody gets 30 minutes. And you think about anybody in this room that spends 30 minutes with their physician. There are no phone calls that night. There's no concerns the next day about, hey, I didn't get a refill. There's no, I didn't get this referral, or I didn't ask you about, sometimes they ask me stuff about their family members, and I just don't care. It doesn't bother me, because I have the time to manage them that way. I had one of my first patients was somebody who came in, we did a pap smear, joint injection, blood work, and she could not believe that on leaving that there was no extra money that was coming out. And the reason I can do that is that the cost of a lab, for me, is usually in the $3 to $5 range. If I sent you from corporate and you had no insurance, the cost you would get charged would be $30 to $40. The charge to insurance for that same lab is $80 to $100. How about there 3 prices for the exact same lab? And how are we okay with that? All doctors know this. And Jeff and I were just having a great discussion that I refuse to believe that physicians want stuff this way. But what do? Do you stand up and say, well, I'm going to fight against Baylor and THR and HCA, and you go out and you protest, and all of a sudden you get a pink slip the next day? Nobody's going to risk it, right? It just won't happen. In my country, there was a time where the physician, this was long before I became a physician, they pushed back against the government and said, we're underpaid, we're overworked, and the government said, yeah, that's real nice. And they said, no, well, listen, if at this time next year or in early January this continues, we're just not going to come to work. And they didn't. And on January 1st, there was an emergency parliamentary meeting, and they fixed it. And that's what I'm trying to get doctors to realize, is that we still hold the cards to fix stuff. It's not as easy as people think. I read an article last weekend where a doctor was leaving clinical medicine. He said he'd been chastised too many times by his patients, who said, why can't you guys fix this? And he's like, but you're telling the victim to fix something, and it's just not that easy. And I know that because when I look at my contract when I was with THR, how do I fight this contract? We all know the contracts are not written for us, no matter what company you work for, and you don't have a choice. When I left residency and I spoke to my lawyer, he said, listen, you can look at this 30-page contract, there's one page that matters, and it's your addendum. Everything else is written for the other 500 doctors, nobody's gonna change it. And you accept that you work for a big corporation, and it is what it is. But what I'm hoping to see is a shift to where patients are not depending on what is insurance gonna cover, but it's what my doctor can provide for me that doesn't require me paying massive premiums with also big deductibles that don't cover anything. So in almost 7 months, I've grown from my first week where I had 6 people and had a little bit of a panic because there was no money coming in, to almost 400 members. And that's been huge. I have people that live in Oklahoma, Connecticut, Decatur, everywhere. Because if you think about it, you're not seeing me every day. So my patient lives in Decatur, sees me once or twice a year because I know what she has. The rest of the time I'm sending in stuff. I can FaceTime them. They can send me pictures of different things because I'm not billing anybody. If you wanted to practice true telemedicine, there's a whole different realm of billing and coding and stuff, which is just garbage. When I grew up in Trinidad, you were expected to have your doctor's phone number, to reach out to them when you're sick, and to not have these 5 different middlemen in between you. When I leave for the day, every single phone call comes directly to my cell phone, and I have this awesome patient that a couple of Saturdays he was out cutting grass, and he fell in some poison ivy. And so he calls me on a Saturday morning about 8 o'clock, and he's like, man, I'm so sorry to bother you, but I found in some poison ivy. And laying on my couch, from my phone, I can fix it. So what takes me 2 minutes changes that person's weekend. That's the right way to practice medicine. It's not, well, I'm sorry, but you can't talk to me because you have to talk to my MA and my nurse. And that same attitude is transferred into the nursing home for me, where the one thing the nurses know is if they call me, I'm gonna answer. Don't take a job unless you know you're gonna do it well. That's always been the way I feel when I was teaching tennis, when I was doing stacking books in a library, is you just have a little bit more self-pride. And that's where I think that as physicians, we're just losing some of that. And we just see the inability to fight against corporate, which is rare, because you can't. And I don't want them to leave in open practices like they did before. I want them to leave with models like this because it's possible. And going into next year, I was just telling Jeff that the next place that I'm looking to open a satellite office, which is crazy, is Houston. And the reason is because I'm gonna make that into a corporate setting. There are 5 or 6 companies that have approached me already and said, hey, listen, we run a limo service, bus driving service, we have 60 employees, we offer insurance, nobody takes it. It's $1,500 per month. These guys barely make that. So for me to be able to say, well, yes, I can be your remote physician, and I'll go there once a month and make sure everybody gets a yearly physical, and I can still order labs that are free. There's no reason that this model can't grow. I've seen specialists do it in a sense where they still have a membership fee, and then they charge you extra for colonoscopies, endoscopies, and that's fine. My pet peeve with that, a specialist is a consultant. They should not assume full care of you. So the days where I send somebody to a cardiologist and the cardiologist sees that you have Blue Cross Blue Shield and says, well, this is nice. I'm gonna make sure they come back and see me because I'm gonna get reimbursed well, so they'll see me 3 or 4 times a year for congestive heart failure. That is absolute garbage. I can manage that, and I should manage that. We were trained in primary care to manage all of these things with the assistance of a consultant. So I send you to the cardiologist and say, listen, I've started the blood thinner, you're on a beta blocker, you've got an echo, they don't have congestive heart failure. Do you have any other suggestions? Nope, looks good, done. That's how primary care is supposed to be. In the corporate world, you are, what's the right word? Strongly encouraged to start spreading the wealth. And that's just a ripoff. Why should my patients have 4, 5, 6 specialists when I'm the one that gets the phone call? Hey man, my inhaler's not working. I'm like, well, wait, what inhaler? Nobody even told me you were taking this. Well, I saw a pulmonologist last week, and I can't get through to them. It's much more difficult to get in touch with your specialist than it is with your primary care. And so I I have a lot of respect for specialists, but I think that the word consultant is more appropriate because that's what they're really there for. Obviously, if you are end-stage COPD with sarcoidosis, lung cancer, sure, pulmonologists are probably worthy, mainly because they can get stuff approved that I can't. But they're the same drugs, they're the same studies that we read. They're trained to do procedures that I'm not, and that's usually where I send people out to. So I practice very comprehensive family practice medicine. I don't believe in sending people out that are diabetics to endocrinologists. I don't think that everybody with blood pressure needs a cardiologist, COPD doesn't need a pulmonologist. You really try to keep everything in one place. And how silly would my practice be if I said, yeah, come on in and pay me $75, and now I'm gonna send you to 5 different docs. It's completely useless. So in general, I've been very, very happy since I've left. I think that my patients are very happy. They have access to me all the time. And you always think, well, okay, there's gonna be somebody that's just gonna annoy me, and yeah, sure they are. Right, that's the first thing. But let's think about this, right? The percentage of people that do that is so small. And it's also the other reason that I make sure to keep the price at a point that I don't have to kiss somebody's ass forever. If I'm charging you $15,000 a year and you come in and curse out my staff member, I'm gonna have to sit there and say, well, but they're paying me 15 grand a year, I can't fire them. My patients treat my one staff member very well. They're never rude to me. Yes, there's some people in their 70s that they're bored and they just call. And it happens all the time. But who else is gonna take care of them? Right? Whether you have Medicare insurance, probably half my patients have some form of insurance. And I just tell them, try to change your plan to something that's more catastrophic. Because if you're paying a premium of $400 or $500 a month for a deductible of $5,000 and you're pretty healthy, why not pay a premium that's lower? You're paying a membership. Yeah, let your deductible go up. I'm not gonna send you to the hospital. I'm gonna do everything I can to keep you out of the hospital, even on weekends. So I've had a lot of patients start going and changing their plans and saying, yeah, I was able to save $300 a month just because I chose something with a slightly high deductible and my premium's lower, but I'm paying you $75. I did a presentation to a dental office the other day, and the guy said for him, his wife, and his 3 kids, he was paying $3,000.
Wow.
That is absurd. I mean, the fact that, and this is where you know that $200 billion comes from. What bothers me about the insurance companies, there's one way they make money. They take money in, and they don't pay it out.
That's right.
There's no other way that they're making money. So they're not, these are not things of their investments and their equity and all this stuff. Those are totally different numbers. This is straight up revenue that we're taking money in and not paying it out. So I'm hoping that as I do some more talks and as I spread, that more physicians will leave. I'm not worried about competition because it's not competition. There are more than enough sick patients. And the other thing is when I was in corporate medicine, I had 3,000 to 4,000 patients. I can't manage that many right now. So even if people started forming these around me, you're aiming for maybe 800, 900 patients. So there's never too much competition. And the other funny part is you look at all the people I had in corporate, most of the people that I have now could not come to that office because they couldn't afford that $300. So I'm gonna open it up to you guys for whatever questions you have. You won't offend me, be devil's advocate, ask me whatever you'd like. Yes?
For the Dr. Stone, you haven't mentioned yet, and I would love for you to say is the fact that the $75 will cover one person, but you have a family plan.
Yes, thank you. Thank you for saying that. So $75 is for one person, a couple is $140, which is a little bit cheaper. For somebody under 21 is $50, and for a family is $200. And the family plan, I don't care how many kids you have, and your kids can be under 25. Yes.
How does this tie into Obamacare?
So good question. Are you talking about the mandates and all that type of stuff?
Mandate.
So as far as we know, the mandate is gone. I don't think until anybody files their taxes, you're gonna feel comfortable with knowing for sure. But what I've talked to my accountant about was, okay, I can't ever tell my patient.
I'm paying you, so how do I verify I don't have insurance?
So, right, so as far as we know, the bill was passed where you don't have to verify that anymore. However, until next year comes around and we all file taxes, I agree with you. I don't think anybody's gonna be comfortable until you go through that process. But even if there's still a mandate, what my accountant said to me is, listen, there are things written in the tax code that if I call my practice Denton Christian Family Practice and have it under religious guise, that it can be used because there's an exemption for it. And she said that theoretically they can't knock somebody for not using a religious name to have it. So in her opinion, she says, listen, you send it in. If the IRS says you don't have it, you're kind of in the same boat you have anyway. I would never tell somebody don't have some catastrophic insurance.
Is this
That
kind of like MediShare?
I think Medisure does a lot more stuff in the hospital,
Well, this is
but
different.
in my own, I mean, what you pay me, there are people who will see me twice a year, there are people who see me twice a week, and that's not a joke. I have new diabetics that they see me every single week. How amazing is that for them to come in every week, I go over their medicine with them, and within a month, their sugars are perfect. I would love to do that in corporate medicine, but who's gonna pay me hundreds of dollars every time they come in? It's impossible.
Well, I had a staff of 40 people at one time,
Mhm.
and when the mandate came down,
Yep.
the basic minimum wouldn't even do anything.
Yep.
It's like, it was useless
Yes.
for my employees, because they couldn't afford anything.
You're
else.
absolutely right. And I think that that's something that I would tell everybody to look into, because this was a big discussion about 6 months ago that the mandate was gone and that it was signed out of power, but I don't know the details as to whether it's gone this year or if it's starting next year. But it is frustrating, because to force somebody to buy, that's like forcing somebody to buy all types of car insurance instead of just, well, if you screw up, you can help somebody else. But it's insane.
And I don't see how the care can get any better.
No, I agree with you. It's a very frustrating thing, because, I've had insurance. When I had insurance at THR, I went for knee surgery, and before anybody touched me, I paid $1,500, and I was like, well, wait a second, like, what am I paying? And it's really nothing. The coverage is just bad. The problem is the people who make these decisions in Parliament, they all have the greatest healthcare known to mankind. So they don't understand what it's like. I didn't have insurance for all of my 20s, because I'm not from the States. I didn't think about buying insurance. And then when I went to med school, I was like, geez, I was pretty lucky that nothing happened. But it can bankrupt you. It really can. When I've met with financial lawyers before, first or second every year for bankruptcy is medical bills. How is that possible in a first world country? That is absolutely insane. What are the questions you guys have out there?
Where do I sign up?
So I will.
I want to say it, but.
No, I will leave all my information for you guys, and you can go on the website, and then if you call next week, my office manager Kim, who I stole from corporate, she'll be happy to sign people up. Yes.
Okay, so what about families that have behavioral health needs,
Mhm.
or, they have a child that's born with, a disability? How are you able to help them?
So I help them in every single possible way that I can, and I say that I had a girl who, she was in an opioid addiction program, but couldn't afford the counseling. Well, she doesn't have to pay me every time she comes in, so I saw her every week, and my days are just not that busy, because I can spend so much time with people that I'm still on. When I was in corporate medicine, I saw 30 to 40 people a day, and I made them a ton of money. Didn't make myself a ton of money. I saw where the money was going. In my day now, it's maybe 8 to 10 people, and that's a joke, but it's a joke in a good way. So if somebody needs an hour, I can give them an hour, because it's not an hour every single day, it's an hour every couple of months or whatever it is. So in this case, obviously there are things that I can't do, there are things that are outside either my scope or just, I would love to cover all imaging, but I can't, it's just too expensive. But you bring up a good point. What happens when somebody finds something and they need somebody else? People always say to me, well, okay, you do a free PAP on somebody and then they find someone abnormal and they need a colposcopy, and well, what are you gonna do then? I said, but that same person would have never had a PAP. Like, I'm providing stuff to people that would never ever go to and I don't blame them for it. Why would you go and pay your yearly physical $500, $600, $700 for something that's normal? And if it's not normal, then now you're terrified and think, okay, we now have to go spend more money. So for me, this is where I want medicine in the States to change. At the primary care level, we all know that for specialists it's different because you're affiliated with hospitals. Hospitals have very high rates of everything. It's just the way it is. But at the primary care level, we don't have to rip people off to make money. We just don't.
So who is this insured, is this for, what's, because I work for a big corporation, and they, they practically pay for most of my insurance.
Yeah, and that's great. And so,
Yeah.
listen, I had professors at UNT were my patient in corporate, and they said, listen, man, I don't pay anything. My insurance is great. You don't have to come to me. I would never be offended. I can't take on every single human being in the world. So I'm never offended, and some people just really don't need my kind of practice. Some people with really good insurance follow me just because we have a great relationship. But also, if they work out, well, wait a minute, my deductible is $2,000 and doesn't cover my labs, but I can pay him $900 a year and it covers everything. For some of those people who still have good insurance, they work out the math and realize that it's still worth it. And that's why we grew so fast. We've really not, yesterday was my first day to meet with an advertising firm, because this was just all word of mouth and people coming in from different places. And the cool thing is now I'm starting to do more and more companies, and that's what I really like. I have 4 or 5 companies and 10 to 15 employees. Can't offer any health care for them because it would cost them $8,000 to $10,000. Some of the businesses decide, well, I'm just paying for everybody's membership. So if you really think about it, somebody has 10 people, you get a 10% discount. You're gonna pay $675 for your 10 employees to have free primary care. That's a good expense to your accountant. Some of them say, well, listen, I want my employees to be very proactive, so I'm gonna pay half of it. So half of it is $300 and something that they're paying. But then they pass on the rest of the money to the employee that works out to about $16 a paycheck. And it's not perfect, it's not hospital insurance, but for free primary care, and I always say, if I can avoid one urgent care or one ER visit for somebody, it pays for itself. Because, again, I've worked in those places. You come in there with poison ivy, you're not getting steroid pills, you're getting a shot because I can bill for it. And the way I get paid in some of those places is not based on RVUs, it's based on production, so the more money I make for them, the more money they pay me. The entire system is broken. Because the patient is there, and I don't know what insurance Jeff has to know if he's covered his deductible. So I'm running up all these extra bills, and then he gets it. And what can you do? There's nothing. Yeah, I mean, everybody's experienced stuff like that. We're like, well, why is my urgent care bill $1,500? And it's because they've given you an injection, an unnecessary x-ray, and I don't blame them. I mean, my biggest pet peeve, I think, with urgent cares, they only exist because primary care doctors don't see their sick patients. It's the only reason. They don't want to get called after hours. They won't fit them in. Why else would a place that you can't triage somebody to a hospital ever exist? And I mean, that's us. We're the reason for that. We sat back and allowed Care Now and all these other places to come in and just say, okay, well, hey, when my patient's sick, just send them there. Their insurance will pay for it. But it doesn't. Exactly. And here's the thing, right? So imagine if you worked at that place and somebody came in, you would overtreat them because you have to. If they went in there with a viral infection, you're not going to not treat them. You're going to send them home with something. Otherwise, they're going to feel they wasted their money. So, what else? Yes?
I was just going to make a point you pointed out earlier about being the primary physician and having the primary overlook of the patient. Is what most of us forget in this industry is that physicians, when they go to med school, they do focus on the psychiatric, they do focus on the geriatric, they have that practice, they just chose not to specialize in it. So someone like a Dr. Stone's physician is able to properly assist, diagnose, and proceed, that you would not have to go to a consultant, as I refer to him as well.
Right.
Because you're getting a one-stop service. And I'm an example of that. I'm a cancer survivor times two. I have great insurance. I refuse to use it. I've been under Dr. Stone for the past 6 months. My medicines bill has cut from $1,000 to $200. My deductible, my deductible is even a joke because it was a $5,000. I wouldn't have to put anything towards it. I just pay my $75 to Dr. Stone. I see him when I want to see him, and I'm a lot healthier now than I was 6 months ago because corporate doctors. Number one, I couldn't get to see him right away. I had to wait a couple of weeks, and the guy was even my friend and my cousin's best man at his wedding. Okay? And I still got hit. Not only his office charge, but every consultant he sent my labs to tell me the same thing. You're cancer free. I've known that for 5 years. Okay? Why do you have to give me that every, month? But everybody got a piece of the cake. So finally, I told my wife, I've got good insurance because my wife, she works for the state. So I said, get the lowest deductible for me. And in the past 6 months, we've seen that savings.
Thanks, Peter. Going back to your point about psychiatric stuff, yesterday I was talking to one of my students and I said, in family medicine, all the regular stuff you have to know. What you have to be good at is musculoskeletal medicine and psychiatric medicine. When you send most patients to an orthopedic surgeon, they're going to see their PA or NP. I have no problem with them because they're mid-levels. There's no way I'm sending my patient to them for something I can take care of. That's just ridiculous. There's no, and you know this because from where you work, it is so hard to get in to see a psychiatrist. It's not even their fault.
Right.
They're just that busy. So it's my job to manage bipolar, depression, anxiety. I've had to manage some schizophrenics because they just can't get in. And yes, of course they can go to somewhere like Mayhill or they can go to the hospital, but going to a general hospital to see a regular ER doctor is a nightmare. Because they're gonna load you up on Haldol and then start calling him to be like, hey, come take this person. And that's just unfair. It's unfair to the patient to just, to treat them that way. And again, how do I blame primary care doctors who work in big corporate offices when they're given 15 minutes to deal with a brand new patient that may have bipolar? It's impossible. Or somebody who just lost their parent and they also have diabetes and they have this, and you say, well, okay, come back and see me, but then there's another copay or they haven't met their deductible and they just won't. And I don't blame patients for that because it's a lot of money to spend when you feel, but I was here and you told me we can only talk about 2 or 3 things. And so for me, when I tell somebody come back next week and it's free, they will come back. You'll probably come back with 3 other problems, but it's still okay. You know?
Now, do you do an
What's so good about
assessment?
that is that you're taking care of them and the condition doesn't get worse.
Right. Yeah.
Because they don't wanna go back, because they don't wanna spend the money.
Yes,
Right.
exactly. And you know, like I've always said, the worst thing for me in corporate medicine was bring everybody back to go over their labs. That's, why would I go back as a patient if I can look on my portal and my labs are normal? From the administrative standpoint, yeah, but you know, you can bill a 99214 and you get the copay. I'm like, yeah, that's great, but if I was a patient, I'd be very upset about this. When I bring somebody back for their labs in my model, they actually feel, okay, he wants to talk to me about being pre-diabetic, my cholesterol is a little bit high. Most of the time, I'm not gonna start him on medicine, but that's my 30 minutes to say, hey, listen, in 6 months, if you're not better, we are gonna start medicine. That is not a conversation that should happen with my MA over the phone. And it used to in corporate medicine. I couldn't call everybody back when you have 30-something people.
So if you take on a new patient and do you do like an assessment and say, okay, I'm on 10 different medications and I'm seeing this doctor for this and this
Yes.
doctor for that?
Absolutely.
Can you say, okay, well, you're a good candidate for me, or you might not be such a good candidate because of all your needs?
I can honestly say I've never turned somebody away.
Okay.
Honestly, I mean, I'm very honest about what is in my scope and what is outside of my scope. There are some patients, I have a lady who is still trying to decide if she wants to see me because she takes medicine that is usually prescribed by only pain management doctors. And this is not just your regular, I mean, this is stuff that is usually for cancer type pain. And I said to her, I said, listen, if the documentation is right and your pain doctor is okay with you seeing him once a year, just for a consult, not even to write your meds, but to supplement my documentation of the need for this, I can do this for you. And that's what everybody should do. Because it's not like I know everything by any means, but it's my job to take into account the person's finances as well. So where my office is located is right adjacent to Denton Prescription Shop. Pretty much inside of a pharmacy. Well, how cool is it when I walk over to the pharmacist with you with no insurance, and I say, hey, listen, I'd like to start her on an SSRI and some blood pressure medicine. What's the cheapest one you have? What does it cost for 30 days versus 90 days? Because for me, even if I wanted to be selfish and say it's for business reasons, if I can save you $20 here, $25 on a different medicine, the membership fee drops down. Meaning you just have more available money to spend on your membership fee. And to watch a patient's face when they see a pharmacist and a doctor arguing about the system to fight to make you pay less, that just never ever happens. And those are the rewarding things for me, is to see how happy somebody is to say, man, this guy saved me $50 a month on medicine, so he pretty much is making my membership fee $25 because that money is now free. So there's a lot of incentive for me to save people money in a lot of ways, whether it's stopping you from seeing or just advising you, your A1C is 6.5, why are you still seeing an endocrinologist? I can write all these meds. Talk to them and say, can I see you once a year? And if the specialist is smart, they would say yes, or you don't have to see me at all until you need me. For a lot of those uninsured patients, the specialist is not going to make a ton of money anyway because they're just, you know, cash prices are sometimes a little bit lower than insurance. And plus, no endocrinologist is dreaming of seeing a diabetic patient. That's a primary care problem. Endocrinologists are trained to parathyroid, thyroid, adrenal glands, pancreatic too. I mean, that's what they're excited about. They're not excited about seeing somebody with an A1C of 7, ever. Unless they're in corporate medicine and they have very, very good insurance. And that's me just being very honest, because that's their way of making money. Is you can get through those patients really fast. You have the MA bring them in, get their finger stick, get their this, do all their labs. You review them, you walk in the room and say, hey, you're doing great, A1C is wonderful. And they're like, oh yeah, this is good. And then they leave, and that's it. You feel pretty good because your labs are good. They're billing at a high level. But that's not real medicine. That's stuff that could be done over the phone.
And it's sad because you're not gonna be able to, all these people that are on Medicaid and Medicare, you know, because they're the ones that really need to see a doctor every.
So
Yeah,
I
all the
have, I'll
time.
give you a perfect example. I have a patient of mine who was having 3 or 4 seizures a day since he was about 8 years old. His mom came to me and said, you know, would you be willing to see him? He's trying to apply for Medicaid, but he can't get it, and et cetera, et cetera. I said, sure, let him come in. He was just running out of his pills. So I saw him, did an assessment. It's a drug that I've written before 1,000 times in the hospital, restarted him on it, and then she canceled the membership, which is gonna happen, right? Some people are gonna try to just do that, and that's fine.
Yeah.
It's not fine, but it is, because it's an insult to the rest of my members. Not for me, I'm not gonna fight you over $75, but
Yeah.
we usually tell people, listen, we're gonna charge you for 1 extra month because I'm legally responsible for an extra 30 days. And most people get it. They were just like, nope, we're done. I was like, fine. How many neurologists have taken Medicaid? Nobody. So 2 months later, they came back and said, hey, listen, he has Medicaid, but he can't see a neurologist. No primary care doctor is spending enough time with him to manage his seizures. We're willing to come back and pay your membership. And of course I'm gonna take them back. You know, if somebody did that repeatedly, eventually, to stand up for my members, I'm gonna say, listen, we can't do this anymore. But this is just a case of, even sometimes when you get insurance, that now you have to figure out, well, who's in my network, And that's always the right question to ask. It's not, do you take my insurance? And dentists are my favorite for that. They take everybody's insurance, but are not in network with anybody. And they charge you on a network rates. So, listen, I'm not here to sound like this, you know, oh, woe is me, the world is ending type stuff, but there are things that we can do to fix this. And I feel really happy that I've kind of broken away from this stuff, because it's just been an education for me to see just in so many different ways where things are broken.
I'm in the military too. My daughter's in Fort Hood, and they're moving back. Her husband got medically discharged from his back, but she's got a lot of health problems. She called me out on her, she's crying. The doctor's there. You can only speak of one thing.
One thing,
Say
yep.
she's got heart or whatever she's got going on. She can't ask him anything else.
Mhm.
He will cut her off. She's
Yep.
called me crying numerous times. The doctors here that she went to, they, you know, she was doing really well. She went down there. Her health just went.
Yeah.
And,
And
you
listen,
know,
there's no way that I would like to think that that doctor went to med school thinking, I can't wait to get out so I can just see one person for one problem. There's
And-
no way that that's what they really
he
believe.
apologized, and he
Yeah.
apologized. He
Mhm.
didn't want to do that to her, but he has.
Yeah.
So she's coming back, so I mean, cause I don't know how their insurance, you know, I don't know what they're gonna do about
Right.
insurance, cause I don't know how long he'll have it, so.
So when I walked in, Jeff made a comment to me and said, man, you know, you're making other doctors look really bad. And, but honestly, what I said to him is that that's the opposite of what I want to do. What I want to do is empower other doctors to realize that you don't have to sit back. And yeah, when you get out of resident, absolutely, you want to take that job for 3 years, that's fine. But then find a way to get away from it. And, you know, to open my practice, I basically saved whatever little bonuses I got for a year, and I said, this is what I'm opening my practice with. You know, most of the stuff that I bought, I shopped all over the place. I rented a U-Haul, drove it down to Duncanville to pick up the OB-GYN bed. Me and two other guys lifted it in. And my brother's on the phone with me, and he's like, what are the doctors driving a U-Haul? But the funny part is, like, I would have it no other way. Like, I would never spend that money on stupid stuff that I could be doing for myself. So it's been a really fun experience, but it's never to try to make other people look bad. This really is something that I wish other doctors would look at and just say, yeah, I can do this. I can break away from it. And there's never going to be too much competition because there are enough sick people, and your practice amount shrinks. I don't want 2,000 people because then I can't practice good medicine. In that case, then I can hire somebody else.
So what do you do on a Saturday when somebody calls you up and says, hey, my kid was outside and they fell and looks like they need stitches?
So those things I can't, because if I'm out of town, then I'm out of town, you know? But
Okay.
usually what I tell them is, send me a picture and let me look at it. Because, and this is the thing, like, this is what we were trained to do.
Right.
We've just been brainwashed by our legal and risk departments at every hospital system. Don't treat stuff over the phone. And
So if I did something, cut my leg up,
Mhm.
and came over to you in Denton, and it was during office hours,
Mhm.
then you just stitch me up and go on about what? Okay.
And by the way, I don't have poison ivy anymore.
Stay away from here.
But no, I mean, I really do, I'm always honest with my patients. If you come and say, hey, I'm having chest pain, no, don't come see me. Like, what am I can't do anything for you. Even with a normal EKG, that is not ruling out a heart attack.
Yeah.
I wouldn't waste your time to come see me. Go to the nearest hospital. So this has allowed me to practice exactly the way that I want to, with good evidence-based practice. I'm not worrying about what the lawyers at my practice are gonna say. I had an issue when I was in practice. We lost power at our clinic. Well, I'm from the Caribbean. We lost power like 4 days a week, right? It never bothered me. I read books with candlelight. It didn't even faze me. The next thing I know, risk and legal are on the phone. We gotta shut down the clinic. And I'm looking around, I'm like, man, this is like daylight. We're not in the night. There's light coming in, and they're like, oh my God, can people see in? I'm like, just calm down. I had one more patient for the morning, and this is no joke, right? And this is a guy who never ever came to see me. And my office manager at the time was like, you know, they're trying to make us shut down the clinic. And I was like, okay, well, we have one more. Let me just see this guy. Guy was in a full-blown MI.
Oh my.
And so, knowing that patient, if I had said to him, hey man, no electricity, you gotta go home, he would go home. He wouldn't go to the hospital because he felt that my primary care doctor is the one that should take care of me. And I saw him, he told me a story, I did an EKG, ST elevation, immediately called ER, he went over there. This is where I'm not, and I said it on Tuesday when I did a talk similar to this. A lawyer should be a lawyer, and a doctor should be a lawyer. I mean, geez, God, can you imagine that? That would be amazing, right? So what I mean by that is that I'm about as interested in their opinion of how I practice medicine that they should be in how I would handle a court case. Zero. I'm not interested. Now, medical legally, yes. they know stuff that we don't know, and I don't want to know. Medical ethically, they know zero. And that's a reason that in med school, 2 different people teach those classes. A lawyer comes in and tells you all this stuff that is different in whatever country or state you're in. The ethical part remains the same. And we should never ever be living in the land where the lawyers are, because they're great at living in that gray area and saying, oh, this is not really a self-referral. And everybody in this room all knows these big corporations do a lot of self-referrals. But if you went to court, they're gonna find a way to make it look like they're not. And that's just the way it is. Right, exactly. My job is to make sure that we don't live in that area. And when I've had meetings with CEOs, CEOs of some of these big corporations that were physicians, we did not get along at all. Because I said, but you're a doctor. Like, you know that if the first word out of your mouth is, well, we talked to our legal department, you know it's unethical. That can't be your first answer. You know, and that's honestly, I have good friends that are lawyers and we joke about it. But when it comes to medical stuff, a doctor's opinion on the ethics has to win. And in the corporate setting, you never will win because they pay your malpractice, they cover everything. In my world, I can do whatever I want. And it's really been a lot of fun because my patients can tell I've been the exact same person no matter where I practice, no matter what kind of job I had. But my patients can tell the different atmosphere in a room. They walk in, there's no stupid paperwork. You come in, I take your full history. Almost every visit's like a full physical. And I mean, Jeff has outed himself here as being one of my patients. So he can attest to this. Everything is just very, very open, and it's just been a lot of fun.
You don't have malpractice insurance?
I do, because I have to.
Okay, because
Yeah.
it's required?
Yes. But, I mean, I'm not getting it for like any kind of fancy craziness, you know? Yes.
So how has your model allowed you to be such a good post-acute partner?
Oh my gosh, it's been so different because I'm glad you brought that around. So truthfully, I was there at 6 a.m., noon, and 6 p.m. In the morning and the evening, nobody's there. Peter's not there. The DON's not there because that's not their work hours. So being able to go there in the middle of the day because I have a gap from 9 to 11, it really changes my ability to meet with families, to meet with Peter and Jerry Lynn. You know, one of the big things that we've really tried to do is to just cut down on readmits, people going to the hospital, because, you know, when I did an educational talk for the nurses a few weeks ago, and that was a big focus. Is how do you address stuff with the physicians instead of calling them up and saying, hey, Mrs. Smith has shortness of breath, it's 3 in the morning, and that's it. Every doctor is gonna say, send them to the ER. If you call and said, this person's short of breath, you want me to give him some oxygen, do I need to get an x-ray, lab work, there's a much higher chance to say, yeah, that sounds good, call me back in a few hours. And so we've worked really, really hard on cutting down on readmits. And the number one thing, listen, for me, it's not about what we see on our QAPI numbers, and all, that's all fine. It is miserable for that patient at 3 a.m. to be dragged out of their bed at 80-something years old, taken to a hospital to just be given some oxygen, get stuck. And of course, traditional Medicare, they're getting CT scans, they're getting everything done because, and this goes back to the same financial thing, it upcodes everything. And that doctor's pay is based on all of those things. So it really has helped my ability to cut down on readmits, and I think just to be a better doctor in general because I don't have to rush through anything. I can sit there for 2 or 3 hours if I want to. Yes.
So if I pay $75 a month,
Uh-huh.
what, for you to be my doctor, that doesn't cover my hospital, it doesn't cover, things that you can't do.
Yeah, I mean, anything
So
I
who pays
can
for
do.
all the, who pays for all that extra, we do?
Right.
Right.
What I try to say is because I try to cut down on your specialist, and because I'm always accessible, is for, I mean, if any of my patients ever told me about I went to urgent care because I had a UTI or a sinus infection or basically anything, right, I'd be upset. I feel like I failed them because I didn't communicate well enough to them. And they're like, well, it was Sunday night, I didn't want to call you. I'm like, that is what you're paying for more than anything else, is the access to care. Because yeah, I would love nobody to ever call me,
Yeah.
right? But when I make myself available that way, that Monday morning is so much easier because now when I used to walk in corporate medicine, I would have 35 missed phone calls from the weekend and you're just catching up. Most of those people have gone and gotten treated over the weekend. So I never try to pretend that I take care of every single thing under the sun, but the ability of somebody with CHF or COPD to call me on day 1 of an exacerbation or be seen that day, for me to prevent them going to the hospital, I mean, that's tens of thousands of dollars that they're gonna save. So, yes.
So how often, okay, so you're saying being seen that day. So how many times do you just have walk-in clients of yours
None.
come in?
And that's the one thing that I don't do. Just call me and I will see you or take care of you. Because if I just said, we're gonna take walk-in patients, then I have to sit there from 7 to 4.
No, I mean, your clients that are already your members,
Yes,
okay? They can come in anytime, I mean, can
but
they
they have to
just-
call first.
They have to call first.
And the reason is, because sometimes, and I'll give you a perfect example, it's not that I don't wanna see them, like, I absolutely will see you. But there are times that I answer the phone at 4:30 in the afternoon, I'm driving home, they're like, Dr. Stone, I have to come in and see you tomorrow. Okay, what's going on? Well, I wanna talk to you about my dose of my gabapentin. That is not a visit. And it's not because I don't wanna see you, it's because it's not a visit for you. We're on the phone, we can have this discussion right now. And so that's, the best day for me is a day like today, I had no patients. Does that mean that I'm just like, oh, the laziest guy in the world? No, everybody's healthy. That's the coolest thing about this practice is when I get a day off, it means everybody's healthy and they don't need me. What an awesome way to feel about getting paid. Instead of, in corporate medicine, how many phone calls do you think I would get today if I had 0 patients? What have you done? Why have you pissed off everybody? I mean, that's really how it operates. So I try to tell people, listen, when I don't have people scheduled, I'm gonna go to the nursing home, I'm gonna do other things, just call us. I will see you, and if for some reason you call after hours, I will take care of you. Doesn't mean antibiotics for everybody, but it means a conversation. It means, okay, well, let me give you some Flonase, some Tessalon Pros. If you're not better in a few days, come see me. That's what everybody wants with their doctor, is that trust to where I feel that I know what I have. I've had it for 10 days. I've used everything over the counter, and I don't want to take time off of work. A lot of the people I have work at hourly rate jobs. Why would I make them miss 3 or 4 hours out of their day? If it's something, if you've had a sinus infection for 15 days, there is 0 on your physical exam that will change my plan of care. You're getting antibiotics. The exact same way that if it's day 1, nothing's going to change my exam. If you tell me I have no fever, I have a stuffy nose, that's usually the 30-year-old guy, right? That's just the, I mean, sometimes the biggest babies. Well, I woke up this morning, my nose was stuffy. Well, okay, well, so was mine. I mean, that is, there's nothing to be done. Right. But that's something that they still want to talk to me about. And that's just not a visit. And it's just getting people out of that mindset of, but I want you to see me. Okay, if you really, really want to see me, that's fine. But if you're calling to talk about medication, I'm trying to save you a trip to come in. And that's what people, that's what you would think that's what people want. Who wants to come and sit in a doctor's office?
And let's set up a business, let's say, why don't we sell humidifiers like for the stuff?
For the stuff he knows we should.
Yeah.
And just
We
upcharge
should.
everybody.
Yeah.
Get the money that way, right?
Let's talk about it.
Yeah.
You know?
How many of you have a doctor that you can call on a Saturday or Sunday? And I gotta tell you, if you've ever had that kind of poison ivy, it's bad. But I felt horrible. I apologized to Dr. Stone. I said, I'm sorry about it. He goes, this is what I do.
It's what you pay for.
And he answers the phone, which freaks you out.
It really freaks you out. And I work in DME, and today I have a patient that I need to get paperwork on, but the specialist is closed. I can't get that paperwork till Monday now. So that patient's gonna have to wait for that oxygen until Monday because of insurance.
I think one of the things that makes a difference at our place, echoing what Joe was saying, is the accessibility not only to our patients, but to our families. The fact that he directly visits with them within less than 8 hours, 24 hours of admission, Dr. Stone is here to visit with them. Does not only want to hear what the nurse has to say, but wants to talk directly to the patient and to the family and assure him that they have now come into his practice. And that's beyond amazing.
But guys, honestly, this just goes back to just having some pride in your job. That's it. I'm not better or worse than anybody else. It's just, don't go work at a nursing home if you don't want a nurse to call you. It's that simple. And I mean, we all joke about, we have physicians at that facility that the nurse can't get them on the phone. I mean, even last night, they called me because they couldn't get in touch with their physician. Doesn't bother me one bit, but you wonder, why did you take this job? You know, and that's the weird part. It's like, I have friends that are OB-GYNs, and I stopped delivering babies after residency because I didn't want to go to the hospital at 4 in the morning. And my friends would just be whining, oh man, this is ridiculous. I said, but you're an OB-GYN. So, and that's the thing, is that I think that unfortunately, doctors have gotten away from just the real reason they became it. And I know that patients think that it's them. I'm sure part of it is to blame on them, but you're restricted with so much stuff that you can do. And I'm hoping that going forward, that more and more physicians start breaking away. And you don't have to open up big fancy practices and charge people hundreds of dollars. I mean, I'm not doing that, and I have no intention. I'm sure my price some years from now will have to go up just with regular inflation, but it's not going to go from 75 to 150 because then I'll lose half my patients. But more than that, it's not even just the money part. It's just you're doing the right thing for the right people in your community, and sometimes it's just how you do it. Anything else?
Yeah, you owe me a lawyer.
Thank you guys. I appreciate it.
Thank you.